My name is Christine Hamp. I am president of the National Grange. Thank you all for joining us this afternoon. We at the National Grange are excited to host an important discussion about ways we can support patients' access to non-opioid medicines through state policies. For those of you who aren't familiar, the Grange is a family and community-based organization that provides members with the opportunity to learn, lead, and make a difference through community service, grassroots legislative advocacy, and educational programs. We operate at the community, county, state, and national levels to ensure members' voices can have maximum impact, especially across rural communities. That's why today's topic aligns with our mission. Pain is one of the most common reasons for patients to see a doctor. Recent estimates show nearly 80 million Americans experience acute pain every year, and patients frequently experience moderate or severe pain at discharge from a surgical procedure. Pain transcends demographics, locations, and socioeconomic statuses, but our collective methods for addressing and treating these problems have not evolved. Opioids remain a prevalent means of treating pain, and research shows clinicians in the US are much more likely to prescribe opioids than those in other countries. A number of non-opioid pain medications are in the development pipeline and have the potential to provide patients with needed pain relief without the long-term harms that accompany opioids. The Grange is committed to improving access and options for all. We want to help policymakers take steps to ensure patients and prescribers have all necessary tools available to comprehensively approach pain management and seamlessly access non-opioid alternatives when appropriate. Again, thank you all for being here, and I'll turn it over to Dr. Robert Twillman, board member at the American Chronic Pain Association and a pain management psychologist at St. Luke's Health System in Kansas City, for more.
Thank you, Christine. It's a real pleasure to be here this afternoon to be able to give you a little bit of a historical perspective on where we've come as far as pain management policy is concerned and where we are now, as well as maybe just a little bit of a peek at where we need to go. Next slide, please. As Christine said, the policy imperative in pain management is really ensuring that people with pain can access all the tools that they need to best relieve their pain. I talk to my patients about the need to have a full toolbox, because sometimes you need a hammer to take care of a problem, sometimes you need a screwdriver, sometimes it's a saw. The whole variety of tools need to be available to people, because pain can vary from time to time, and what's needed to treat it can vary also from time to time. We know that pain, especially chronic types of pain, the pain that people have every day for sometimes years on end, is really complex. It can have lots of different causes, and oftentimes people who have the same cause can have different experiences of the pain. Treating chronic pain effectively requires that we focus on a variety of aspects of the patient's experience. We have to focus on the biological aspects, but also the psychological, social, and spiritual aspects of the pain as well, if we want to do the best possible job we can to treat that pain. We often talk about those four things as being like the tires on a car, and if all four of the tires are flat, you have to really fill all of them up to get the car moving again. And that really describes what we're trying to accomplish with people who have chronic pain. Using all of these techniques oftentimes requires multiple providers, and accessing those treatments can be challenging for several reasons. Next slide, please. So these are some of the reasons why people may have difficulty accessing treatment. First off is misdiagnosis. Oftentimes chronic pain is misdiagnosed for a long time until someone eventually figures out what's really going on. But then on top of that, we have lack of pain care providers, lack of insurance coverage, inability to afford treatments even when you do have insurance coverage. So for instance, physical therapy. each session of physical therapy has a copay associated with it, so that each session of physical therapy might cost the patient out of pocket as much as a month's worth of medication would cost them. The inability, the limited array of treatments that we have available, access to treatments themselves, and risks associated with some of the treatments, particularly the opioids, as we've alluded to before. Next slide, please. This is sort of my view of what's gone on over the last 40 or 50 years in the world of pain management policy. Most of the policy work that's been done has been in the context of opioids, and you see that starting in the 1980s and 1990s. And the code that I've set up here is that one plus sign is a little bit of policy work trying to increase access to those things. Two is a lot of work, and the minuses are sort of the corollaries, trying to decrease access and really decrease access. And that's what you see with the opioids. Around 2010 to 2015, we began to see policies come in decreasing access to opioids, and that really accelerated in the 2020s. For non-opioid medications, we saw a lot of activity in the 2000s and 2010s, but not so much now. Procedures and devices, things like spinal cord stimulators in particular, we've seen increasing activity in the policy realm. Somatic therapies, I'm talking about physical therapy, occupational therapy primarily. The psychological therapies, like I do with patients that I see, have been something we've seen some sort of steady advocacy for. And then the complementary and integrative therapies, things like acupuncture and Tai Chi and yoga and massage and all of those types of things that the people need as well to treat their pain, has been something we've seen more focus on more recently. Next, please. So in the late 1980s, what happened was we became aware that even people who had advanced cases of cancer were suffering with inadequate pain treatment. And what happened was we began a push at that time to increase access to opioids for people with cancer. At that time, we had very few other options to help treat people's pain. And so that's what we went to, was the medications we had available. That push really took off in that period from about 1990 until about 2010, and it began to expand to cover people who had pain that wasn't associated with cancer. But around 2010, we started to see questions being raised about increases in opioid overdoses and deaths related to the overdoses on those opioids. Next slide, please. Since 2010, what we've seen is a sharp increase in policy changes designed to limit access to opioids, saying maybe these shouldn't be the first thing we give somebody who has pain. Maybe we ought not give as much for as long as we have. And so those policy efforts have also included recommendations that we shift our treatment to non-opioid medications and to other kinds of treatments. But unfortunately, the policy that supports improving access to those alternatives has not kept pace. And increasingly, what we're finding is that people who need pain treatment can't access the opioids, and they also can't access the alternatives that are being recommended instead. Next slide, please. So what do we need to do now? Where do we go from here? Well, I think several things need to be done. We need to first support research and development of new non-opioid pain treatments. We haven't really seen a new class of medications for pain emerge since the late 1990s, unless you're thinking about the medications that are used to treat migraine, which may be one exception to that. But aside from that, we haven't really seen much new come out. So we're stuck with 30-year-old medications trying to treat these problems. We do know there are some new non-opioid medications being developed, and some of those might be available as soon as next year, but we really need more work to go on in this sphere of research. We also need to limit the ability of PBMs, the pharmacy middlemen, and health insurance companies to restrict access to these options, because what happens is now people are saying, okay, you can't have the opioids, but the insurance company says, well, we don't want to pay for this treatment either. And you have to jump through a whole lot of hoops if you're going to be able to get it. And even then you may not be able to get it. So we need people to back off a little bit here and allow us to access the treatments that we need. And we need to work with advocacy organizations to make the voices of people with pain heard. As you heard, there are a lot of people in the country who have pain. There are about 20 million people who have something that's called high impact chronic pain, the kind of chronic pain where you have pain every day and it impairs your ability to function. That's out of about 50 million people in the country who have some sort of chronic pain. And so we need to work to help those people make their voices heard so that we can ensure that they have access to all of those tools in the toolbox. Next slide, please. So these are some of the opportunities for people to get involved and advocate, to hook up with some organizations that do some advocacy and that you can lend your support to, like the American Chronic Pain Association I'm a member of, the Pain Collaborative to Advance Equitable Value-Based Solutions, a group that's run by someone who used to work with me at a different organization, the U.S. Pain Foundation, or National Pain Advocacy Center, the Pain Community. You can Google all of those organizations to find out more about them, but they all do some policy work that you can support. The policymakers need to hear the stories of people who have pain and to recognize the struggles that they have to access pain relief. If they don't hear the stories, it becomes too easy for them to just say no to everything. And so when they're able to hear the stories and see the impact of this experience on people and the devastation that it can cause, then they're more likely to support the policies that we need. And the last thing I will say is that every voice is important, so please lend yours to the cause. And we hope that today will be an opportunity for you to begin to do that. Thank you.
Thank you, Dr. Twillman. I will now like to turn it over to Abby Trotter, Executive Director of Life Science Tennessee.
Thank you so much, Christine, and thank you so much for that great bit of information, Dr. Twillman. Again, I'm Abby Trotter. I'm the Executive Director of Life Science Tennessee, and I'm here today to discuss the innovative things that we have done in Tennessee recently to address pain management and opioid addiction. But first, a quick little bit about Life Science Tennessee. We're a member organization, and our companies are leaders when it comes to innovative and novel medicines. We have membership that ranges from large companies and small companies across the state, academic researchers, medical providers, people in the pharmaceutical industry, people in the medical device industry. Next slide, please. We have about 110 company members located across our great state. We host about 10 different events every year. We have about 800 different members attend those events every year. Next slide, please. A little bit of our current membership. Put a slide up so you could see some of our members as well. Next slide, please. We have an advocacy committee as a part of our membership that's comprised of about 40 different people. We put together a robust agenda at both the state and the federal level that we advocate for every year. We'll talk about one of our most recent successes, and it's really one of the reasons I think I'm here today. We did some very innovative legislation for opioid pain relief. But we've also done other legislation to help get funding, to help early access of diagnostics, funding for STEM education, and general legislation that promotes the value of different life science and pharmaceutical technologies. Next slide, please. That advocacy committee and our membership host state policy days every year. We have a day on the Hill, usually that happens in January or February at the beginning of our legislative session here in Nashville. And we actually also go to Washington, D.C. once a year to talk to our congressmen in that area. Next slide, please. So specific to innovation and the treatment of pain and how we looked at it and how we addressed it here in the great state of Tennessee. Obviously, innovation is critical to be able to provide treatment options for people experiencing pain. Despite all the serious societal and economic challenges brought on by opioid abuse and misuse, There has been little innovation, as Dr. Twillman said, in almost 2 decades to treat acute pain. But that is changing. As we know today, there are a lot of different research programs investigating novel approaches to pain, some of those going on right here in the state of Tennessee, namely just a few blocks from me at Vanderbilt University. Some great research is going on. But the opioid problem in Tennessee is particularly challenging. According to the CDC, our death rates from opioid addiction are some of the highest in the country. Next slide, please. And over the last several years, almost every state in the US, including in Tennessee, and some of these numbers that I'm going to be discussing in a moment are specifically to Tennessee, we've taken several different avenues to address this terrible crisis of opioid abuse and overdose. State policymakers, agencies are very familiar with the opioid epidemic, and we have many direct personal experiences with opioid use disorder. And unfortunately, the data shows that more needs to be done in the state of Tennessee. Opioid overdoses were particularly high during the COVID-19 pandemic, placing them among the leading causes of death in 2020. In 2021, more Americans died of opioid overdose than any year in record history, and Tennessee among the states reporting the highest level of overdose deaths in that year. The overdose death rate in Tennessee in 2023 was double the national average, In 2023, Nashville, where I'm sitting right now, had the 3rd highest opioid overdose deaths rate in the country, very unfortunately. And yet, the opioid dispensing rate in Tennessee has consistently remained high. In 2022, the national average of 39.5% dispensed over 100 people, while Tennessee's dispensing rate exceeded 61.5 prescriptions for every 100 people. Next slide, please. So despite an ever-increasing focus on the downstream effects, harms, and costs associated with opioids, Tennessee clearly still has an issue with the amount of opioids prescribed and dispensed. As you can see on this slide, if you know the state of Tennessee, a lot of the dark areas where there was a significant amount of opioid overdoses in this particular year are more urban areas. But unfortunately, a lot of these dark areas are some of our counties that are more rural areas as well, which is where we have very specific problems in the state. Next, and then one other thing to point out on this slide, you know, just in 2022, we had over 38,000 opioid deaths. So it's a real problem that we're trying to deal with. I'm sorry, 3,800 opioid deaths, not 38,000. So next slide, please. So despite an ever-increasing focus on the downstream effects, harms, and costs associated with opioids, Tennessee clearly still has an issue with the amount of opioids prescribed and dispensed. And the reality is that current insurance coverage and reimbursement actually incentivizes the use of opioids as a first-line treatment, while potentially placing a novel non-opioid pain management option at a disadvantage for prescribers. So as an organization, Life Science Tennessee really wanted to tackle the policies and incentives that disadvantage FDA-approved non-opioid alternatives which treat pain. We really wanted to ensure the state laws and regulations created a level playing field between non-opioids and opioids so that doctors and patients don't have to jump through hoops and additional barriers to access non-opioids. So we came up with what's on the next slide, please. So the Tennessee Pain Parity legislation, House Bill 2903, it did 4 main things. Number 1, it required our Medicaid program, which is called TennCare, to ensure that an FDA-approved non-opioid for treatment of pain is not disadvantaged or discouraged relative to any opioid or narcotic on the preferred drug list. Secondly, it prohibited a managed care organization from denying coverage of a non-opioid in favor of an opioid. The bill was signed into law by Governor Lee just very recently on April 22nd. It was approved in both the House and the Senate this year unanimously. It pertains only to our TennCare program, our Medicaid program, as that is often the easiest to effect change within the program directly administered by the state. The legislation was sponsored by some very strong sponsors in both the Senate and in the House. Senator Shane Reeves was our Senate sponsor, and Representative Kumar, Dr. Kumar, was our House sponsor. Senator Reeves is a pharmacist, and Representative Kumar is a physician. So we had some very strong sponsors for our legislation. Next slide, please. Opioid legislation across the country. We're not the only state that had great success this past year. 6 other states passed pain parity or non-opioid awareness legislation just this past year. That includes Georgia, Louisiana, Oklahoma, Maine, Virginia, and of course, Tennessee. Several other states introduced this type of legislation in 2014, and you can see some of those highlighted in the lighter green. So a lot going on, and there's a lot of great momentum to do these pain parity type pieces of legislation, which is primarily what we focused on at Life Science Tennessee just this past year. Next slide, please. A little bit more detail so you can understand the 4 things that I mentioned earlier that are part of this non-opioid bill detail. Number 1, that pain parity, it establishing and maintaining the formulary. An insurer shall ensure that no non-opioid drug approved by the FDA for the treatment of pain shall be disadvantaged with respect to coverage relative to an opioid. That's number 1. We also talked about provider education, specifically informed consent, as we call this in Tennessee. The Department of Public Health shall develop and publish educational material regarding the use of non-opioid alternatives for the treatment of pain, and a provider shall inform the patient of available non-opioid alternatives for the treatment of pain. And then number 3, specifically to step therapy, when a licensed healthcare provider provides a non-opioid medication for the treatment of pain, it shall be unlawful in the state of Tennessee for the insurer to deny coverage of the non-opioid prescription in favor of an opioid. And then finally, the non-opioid directive. The department, some bills, ours did not have this in Tennessee, not yet for this year, but some bills have said that that the Department of Health shall develop a non-opioid directive for indication of healthcare practitioners and emergency service providers that the patient must not be administered an opioid. Again, that's not something we did in the state of Tennessee, but it's a very interesting piece of legislation that we could do. So with that, I think that's my last slide. I'll turn it back over to you, Christine, for any further discussion.
Great. Thank you, Dr. Twillman and Abby. Before we conclude, we have a few questions for both of you. And Abby, you're up first. You mentioned that state policies may actually promote or incentivize opioids as a first-line treatment. Can you elaborate on that?
Sure. Yes. Before we pass this legislation, I think that is very true. The legislation in Tennessee that we just got passed, though, right now, was specific to our TennCare program, which primarily serves children and individuals with extremely low income. It is our Medicaid program. But our Medicaid program and others across the U.S. have policies in place that allow generic opioids to be prescribed without requiring that the provider get prior authorization approval from Medicaid. In other words, there are circumstances within Medicaid in which doctors don't have to call the state to get permission to write a script for an opioid. But they do have to get permission to write a script for other kinds of drugs. So the extra hoop that doctors have to go through before we pass this bill caused an opioid to have preference over a non-opioid. And what we did in the state of Tennessee was level that playing field.
Okay, thank you. Dr. Twillman, a question for you. What are the most significant policy challenges currently facing the field of pain medicine?
Well, I think I alluded to that in my talk. The biggest thing to me is everyone is saying, don't use the opioids as much, use these other kinds of treatments, both other medications, devices, other types of therapies, but nobody's doing anything to make those more available to us. No one is ensuring that we've got enough providers to do that. No one is providing insurance coverage for those things. When they do provide insurance coverage, it's oftentimes in the context of these kinds of prior authorization scenarios that I will tell you that when I talk to my physician colleagues, it's maddening how much time they spend just trying to get through the hoops to get these things available to people. So, in many cases, we have options that will be very helpful to people, but they can't access them because they're all bound up in this system. And we need to open it up a little bit more so that people are really able to use that full toolbox. It's like they have a toolbox full of tools, but they're barred from using half of them. And we can't have that being the case if we're going to be successful.
Okay, thank you. Abby, for you, what is the next step for non-opioid legislation in Tennessee?
Yeah, I'm glad you asked that, Christine, because I think we have several options. I mean, certainly we have not solved all the problems with what we just got done in the state of Tennessee. We've talked about the ability potentially to expand that legislation into other insurers, maybe focusing on state employee health plans and potentially getting into our commercial health insurance plans. There was also some things done at the federal level just in the last couple of years that helped with separate payments for non-opioids given in a hospital setting. So we're looking at potentially separate payments for non-opioids, just given that most of them are new drugs. And so we feel like something like that would also help with their adoption. So we're looking at both of those options in Tennessee as well.
Okay, great. Dr. Twillman, how can patient advocates work with you and others in the pain psychology field to advocate for policy changes at the local, state, and national levels?
I think it's really mostly a matter of getting your stories out there. We often talk about, or I often talk about, policymakers being driven by two things. To some extent, they're driven by the numbers. How much is this going to cost? How many people are affected by it? What's the difference in cost if we do this? But they're also driven by emotion. And so for them to hear the stories and see the impact of the challenges that people with pain have when these policies interfere with their ability to get adequate treatment, that can have a huge impact. And for some, it really will have more impact than the numbers themselves will. So we need to be sure that that side of the story is getting out, that type of information is being shared with policymakers. Remember, these people work for you. In many cases, they're elected. In other cases, they're appointed, and you pay their salaries with your taxes. So, they really need to take direction from you as well about what you see as the biggest issues and the major issues or major problems that need to be resolved. So don't hesitate to get that information out there. It's easy to communicate with these folks these days. So please do it. Please tell them the story so they know what's going on.
Great, thank you. Abby, What work is being done at the federal level around ensuring access to non-opioid pain medicines?
Thanks. So I mentioned just a bit ago some work and some legislation that was passed by Congress recently. It's called the No Pain Act. And once again, what it does is it allows for separate reimbursement outside of bundle payments for non-opioid based pain medicines used in hospital settings. But there are now efforts underway in Congress to do something similar to what we did in the state of Tennessee and some of these other states did that I pointed out earlier. And that is called the Alternatives to Pain Act. And what that will do specifically for Medicaid patients will do some of those level the playing fields between the non-opioids and the opioids. So it will do things like prior authorization, step therapy, ensuring that insurers are not able to have any prior authorization on non-opioids and do not require any step therapy for non-opioid pain medications. So there's some really great things that are happening around the country and some great momentum. And it's great to see in those examples, one thing started at the federal level and went down to the state level, and now some things are starting at the state level and they're moving up to the federal level. It's the way it should work.
Right, great. Dr. Twillman, what initiatives or organizations exist to educate and raise awareness about the challenges in pain policies, and what activities would be most impactful for advocates to do?
Well, I showed some of those organizations with the last slide, I think, in my set. And I think, those organizations are keeping track of what's going on, especially at the national level, but also at the state level. So reaching out to any of those organizations and saying, I live in X state, what's going on in my state, how can I be helpful here, would be really helpful. Those organizations have people whose job it is to advocate and to educate the policymakers about what's needed and what's going on out there. And they can use your stories very readily as well. I used to run an organization where we did a lot of that kind of advocacy. And we made sure that when we went to a policymaker to talk about something, we went with someone who could discuss the facts of the situation, the numbers and all of that. But we also went with somebody who could talk about the human experience of it so that we were sure we were hitting sort of both channels with the decision makers. So just don't hesitate to tell your story. Don't be ashamed about what's going on. Don't be hesitant to talk about your experiences. These are real experiences that have real impact on people. And if we don't tell the policymakers about it, they're not going to know and they're not going to make the changes we need them to make.
Great, that's some great advice for all of us to keep in mind. Abby, last question. Can you talk a little bit to the importance of legislators hearing from advocates and constituents on issues like these?
Sure, and thank you so much for this time today, Christine, and it's great to hear from you, Dr. Twillman. And Dr. Twillman said this earlier as well. I mean, just we're keeping in mind that legislators really do need to hear from their constituents. They need to hear from organizations like Life Science Tennessee, organizations like Grange, and organizations that represent other concerned citizens about opioid addiction and opioid deaths across our country. Legislators are spread very thin. So make sure when you talk to them, you realize and you get them all the great information that they need to know specifically about the benefits of the bill, the challenge that you're trying to solve, and the benefits of the solution that you're putting forward for legislators. We were very fortunate, again, in the state of Tennessee because we had two terrific sponsors on our pieces of legislation. So that always helps to find great sponsors that are willing and understand that there is a problem, and they're willing to and understand that you're offering a great, viable solution. So again, thank you so much for allowing us to talk about what we got done in the state of Tennessee.
Great. Thank you, Abby. Thank you, Dr. Twillman. And thank you all for attending today. As we wrap up the webinar, you will be directed to a page where you can share your contact information. This will allow us to keep you updated on this important issue. We also will send a follow-up email with the link in case you are unable to access it. We thank you all again for joining us this afternoon and have a great rest of your day. Bye-bye.